Hey everyone, welcome to Discussions with Dr. G. Dr. G here, and today we're venturing deep into the wonderfully unglamorous world of hyperlipidemia. Yeah, it's not the hot topic at the dinner table, but let me tell you, cholesterol and triglycerides will decide a lot about how your arteries age, even if you're busy pretending you feel fine. So picture this. We've got LDL, that so-called lousy cholesterol, just stuffing gunk into your arteries, making way for heart attacks, strokes, all the hits. Then there's HDL, the healthy one, trying its best to clean house by taking cholesterol out of the bloodstream. But if you've got low HDL and high triglycerides on top of high LDL, you're stacking the deck for atherosclerotic cardiovascular disease, ASCVD for short, or things like coronary artery disease, stroke, peripheral vascular disease, even myocardial infarction. Fun, right? Now causes. Boy, are there plenty. Genetics can hand you a bad deck right out of the gate if you've got familial hyperlipidemia. But let's be real. Most of us are making things worse with too much pizza, not enough treadmill. Diabetes, kidney disease, obesity, smoking, heavy drinking, basically living like it's your last day every day. That is how you wind up here. And here's the thing I remind my students. Just because you don't feel it doesn't mean it's not happening. I had a patient once, classic, looked right at me and said, "Doc, if it's just a number on the lab, can I just ignore it?" No. The problem is, this stuff runs silent until BAM! You land in the ER with your first MI or stroke. And by then, good luck undoing years of damage overnight. But okay, before you panic, the first line of defense isn't a pharmacy run. It's lifestyle. Diet, exercise, stop smoking. Go easy on the booze. If you catch it early, sometimes that's enough. But if you're already seeing high cholesterol stick around despite kale smoothies and gym memberships, or if you've got something genetic or a condition like diabetes, yes, this is where the medication is going to enter the scene. And yeah, for some folks, especially with familial hyperlipidemia, all the broccoli in the world isn't going to save the arteries by themselves. So moral of the story, don't wait for a symptom because you probably won't get one until the trouble hits. All right, let's talk about what happens when lifestyle doesn't quite cut it. Time to wade into the medicine chest. There's a whole lineup of antilipidemics, each with their own quirks. Statins are basically your celebrities. Atorvastatin, rosuvastatin, you know the names. They block HMG CoA reductase to lower cholesterol factory production in your liver, which sounds complicated, but it just means less cholesterol in your blood. Statins lower LDL. Huge win. Plus, they help with triglycerides and even raise HDL a bit. They stabilize plaque and have anti-inflammatory benefits. But of course, it's not all rainbows. Ever heard of statin-induced myopathy? That's muscle pain, sometimes really, really bad, like rhabdomyolysis. Bad. Bad, bad. Plus, statins can bump up your liver enzymes, so you got to keep an eye on those labs. And grapefruit juice is an absolute no-go. It messes with metabolism and can make things go sideways quick. Oh, and remind your patients to take these in the evening. That's when your liver is the busiest cranking out cholesterol. Fibrates. Think gemfibrozil or fenofibrate. These are your go-to for folks with sky-high triglycerides and low HDL. They work differently by increasing the breakdown of fats, and they help a little bit with HDL too. But yeah, they can trigger gallstones, especially if your gallbladder is already on the grumpy side, and don't get me started on the higher risk of muscle issues when taken with statins. This actually came up last semester. Had a bunch of nursing students hotly debating which would be better for a patient with wild triglycerides and a history of iffy digestion. There's no one-size-fits-all, guys. You gotta look at the whole clinical picture. All right, bile acid sequestrants like cholestyramine. These are like your vacuum cleaners for cholesterol, but not super popular outside of textbooks. Side effects are mostly in the bowels, hello constipation, and they can mess with vitamin absorption. They do lower LDL, but if your triglycerides are already high, these can actually make it worse, so you really have to be careful. Niacin or vitamin B3 used to be all the rage, but honestly, most patients hate the flushing, and it can mess with the liver, the blood sugar, and even uric acid. People forget to take an aspirin 30 minutes beforehand, then call me at 2 a.m. convinced they're having an allergic reaction. Yeah. Ezetimibe is the next player. It blocks cholesterol from even getting absorbed in the gut. Mild stuff, good as an odd add-on if statins aren't quite doing enough, but watch for joint aches and muscle pain, especially if it's combined with a statin. Now, let's talk about the new kids on the block. Bempedoic acid. It's an ACL inhibitor. PCSK9 monoclonal antibodies like alirocumab and evolocumab, and siRNA therapies such as inclisiran. They're for severe or resistant cases, especially with familial hypercholesterolemia. They can drop LDL by a ton, but we're talking injections. Rare risks like tendon rupture, or in case of the PCSK9s, injection site reactions, or even angioedema. But for folks who inherited the worst possible lipid genes, these can be a game changer. Bottom line, there's lots of options, but it's always about matching the med to the patient's risks, side effect profiles, and their ability to actually take the stuff as prescribed, which honestly is often the hardest part. So let's get practical, because real life isn't a pristine clinical trial. As the nurse, you're the point guard, making judgment calls about which meds are even appropriate, checking labs like lipid profiles, liver enzymes, CK if someone has muscle pain. I'm looking for those red flags: jaundice, right upper quadrant pain, unexplained muscle aches, or gastrointestinal disasters. Anyone can memorize a med list, but it takes judgment to spot when something's off, especially when side effects are sneaky or a patient's about to fall off the wagon with adherence. Speaking of adherence, most patients will nod along in the clinic when you talk about lifestyle, but when they get home, it's a pizza world. Educating them that the med doesn't erase lifestyle responsibility is key. And let's face it, sometimes the hardest teaching you'll do is just reminding someone to take their statin at night or avoid that glass of grapefruit juice. I once spent a solid 20 minutes with a client figuring out how to use one of those rainbow pill organizers. Seriously, it was a team effort, and by the end, they were a lot more confident about handling a pretty gnarly regimen. Little stuff like that makes a really big difference. So to wrap up, safe care is more than dosing and dispensing. It's about matching the med to the lipid abnormality, monitoring for trouble early, reinforcing those lifestyle pieces, and teaching patients how to live with these regimens. It's not glamorous medicine, but if you can keep someone out of the hospital and give them a fighting chance against the silent risk, you're winning. All right, folks, that does it for today's episode. There's a lot more ground to cover in the world of cardiovascular meds, so stick around until next time. Until then, take care.